Well, hello, everybody. Welcome back to the Trauma Anesthesiology Society podcast. Today, we are excited to present a continuation of some earlier podcasts. I guess this is number three regarding regional anesthesia for rib fractures. The first one we had this, I actually had to look stuff up afterwards because I had no idea what we're talking about. So I have a feeling this is going to add some more questions for me.
Yeah, I think for me too, it's amazing how much this field, this topic of regional anesthesia for rib fractures just seems to come up again and again in my practice, certainly. Today we're planning to discuss three topics. First, we're going to talk about the approach to nerve block selection for chest wall trauma. Then we'll be discussing the management of the nerve blocks and its integration into multimodal analgesia. And finally, we're going to talk about active patient management, so setting recovery goals, expectations, and education. Our panelists today are Dr. Jerry Jones from the University of Tennessee Health Science Center in Memphis. We're joined as well by Dr. Nadia Hernandez from the University of Texas at Houston and Dr. Riva Ramlagan from the University of Ottawa. Thank you very much for joining us.
Okay, so let's begin. Our first topic today is approach to nerve block selection for chest wall trauma. To start this off, I guess Dr. Jerry Jones, what factors should be considered when choosing different blocks?
There's lots of things. I'll try to consider this as sort of an overarching view as I do it. First, when I get a consult for chest wall trauma, my first thing is to find out are there other injuries. Do they have a traumatic amputation, or they're going to need an X-lap for something, or is it isolated chest wall injury? And then really for me is I'm going to go to the CT scan myself to find the extent and the location of the chest wall injuries. Radiologists in this setting are, they're looking for dissecting aorta and terrible things. They don't necessarily look at all the details. When they talk about rib fractures, sometimes they're a little bit vague about the locations. And also it gives me a chance to see if I think subcutaneous air is really going to get in the way of whatever approach I might have, and gives me an idea maybe where which fractures are likely to be the worst. It's kind of my overall what I think. And I'll say the next for me is then obviously to go to the patient, and I get the patient to list for me, hey, are you hurting right now just sitting there? Are you hurting when you take a breath, when you cough? And then point with one finger. Show me exactly where you're hurting. And for me, I kind of stack that up. Where do they hurt the most down to the least with those factors? And then kind of getting that look at them. And I say, is positioning going to be an issue? Is there somebody that's not going to be able to sit up or allow me to get to their back? And then also considering who this patient is. Are they going to have coagulopathies, or they're on medications that might make some approaches more, may limit some of my options. And then, see if there are other variables. Are they going to need a chest tube that's about to come in, or are they about to go to surgery? Because then, hey, I can turn them over while they're intubated and get to them if I need to. So that's kind of my overarching view. And I'll say that along with this, I'll say at our institution, we essentially never do thoracic epidurals. What we have found is in the trauma setting, there's always new injuries or other things that came up that you didn't expect, and suddenly you've got a catheter in. And then for us, one of our big goals is to get them home as soon as possible. So, we can't even send patients to the floor with an epidural, and I certainly can't send somebody home with a catheter early. So we rarely do those. We're typically doing a lot of ESPs or serratus and parasternal or subpac or whatever you might call those. So it's really kind of, do I need an anterior and lateral wall approach? Do I need something posterior? And is it different on one side and the other? That's kind of my overarching views.
Wow. This sounds like there's just a lot to consider there. Dr. Hernandez, did you have anything to add to that?
No, I agree with him. As far as the CT scan, the radiologists are very vague. And so I think for us at our institution, we also don't do very many thoracic epidurals. I think it depends on, level 1, level 2, level 3, how unstable your patients are, how much blood they're requiring, and whether or not they can tolerate the sympathectomy that comes with a thoracic epidural. Yep. And we've just noticed that in our institution, it's not something that we can use. And like Jerry mentioned, we do send patients home with catheters for rib fracture. So if we can place a fascial plane catheter and control their pain that way, that's usually preferable. And so what I look at mostly is what is going to prevent you from bleeding, because not bleeding, breathing, because in a polytrauma patient, they're going to have a lot of sources of pain. And, they might have, a tib fib fracture that hurts a lot, but it's not going to stop them from taking deep breaths and getting respiratory complications. So I'm mostly concerned about, is the scapula fracture preventing you from taking deep breaths? It does sometimes. The chest tubes, the sternal fractures, and then the rib fractures. If we block the rib fractures, can we do it with the least amount of catheters? Since we are doing fascial plane catheters, right? How can I provide analgesia with the least amount of catheters, especially for bilateral fractures? So, we talk about every area, and we break it down with like what needs to be blocked, what dermatomes, and on what side, and then we make a decision based on the patient. And so, one question that I also get asked a lot is these fascial, interfascial plane catheters, where, when, how. And I have a very simple answer that I give everybody. I think that if you do a deep injection, like on the ribs or on the external intercostal, and you place a catheter there, if you can get that close to the fracture site, that catheter tip, you're going to have analgesia. It doesn't really matter what muscle plane you are in if you're doing high volume and you're close. But it's generally, based on all of the other things that are going on with the patient. So I totally agree with Jerry.
Yeah, you brought up some great points. So I can just add to that. That's part of the decision tree that you mentioned about a sympathectomy. Because if you do a paravertebral, thoracic epidural, or ESP, yes, you will get a sympathectomy, and that may make a difference as opposed to doing something that's anterior and lateral. We don't have to worry about those kind of things. And another piece about it, like where are you going to put them? Are they if you are going to do something posterior, paravertebral or ESP, are the fractures up high? Are they down low? Are they up high and down low? Remember the ESPs, if we tend to put them in relatively high compared to where the band of injury is, because they tend to kind of drift down. You've seen this too, kind of drift down with gravity over time, and in general try to put them in from caudal to cranial direction, maybe to kind of shoot it up higher to kind of keep it in that range that you want. And I agree with what you said about, it doesn't exactly matter what orientation, or don't worry about if you're right over the transverse process. Get in the right plane and let it spread to the place it's supposed to, and that's the way to go. So well stated.
And Dr. Ramlogan, I don't know if there's anything left, but do you have anything to add?
Yeah, pretty much I do this exact same. You got to review the images yourself. And you got to talk to the patient yourself to figure out where the pain is. And yeah, it doesn't really matter where you put that catheter. You put it at the site of the most pain, and it's going to spread. The local anesthetic is going to spread, and they're going to be comfortable. I really just put it directly onto the rib, at least for the serratus plane blocks.
Yes, and we've got to give some more credit to Riva. I've done this a few times. You get a patient with lateral fractures, you could do a serratus, but what if it's posterior and you can't get back there? I've done it a few times, and it actually does leak back there. One of the previous podcasts we talked about, and I've done this lots of times. You got a patient you can't position posteriorly, and he convinced me to do it more often. As somebody with lateral and posterior fractures, you can do a serratus, or we always go deep to the serratus anterior muscle, and it's not a perineural technique, but where all the muscles have been torn up and all that, the local anesthetic preferentially goes, and that's sometimes I've been able to do that, and that's all you got to do. So I've got to give you props from our previous podcast. We started doing that more often.
Oh, that's good to know, Jerry. And I gotta tell you, nothing's changed. I still do serratus. It doesn't matter where the fracture is. Once those muscle tissues are disrupted, the local is going to spread.
Mm-hmm. Do you guys tend to always go under the serratus when you're picking the serratus, or you always go under the serratus
because you have a target? Yeah, exactly. Like the bone is your target. You're not going to get in trouble. You're not going to put it in a false plane. You just aim for the
Mhm.
rib. That's how I teach it. You know, it's easy.
Right.
Yeah, we do that at UT also. We go right for the rib, and you know, if there's a chest tube on that side anyway, it's not dangerous to aim there.
Yeah, exactly.
But
Yeah, and another point, if we're talking about approach to this specific block, you know, you could do it sort of like a parasternal, where you're going to go between the muscle above and the intercostals, right? So we have rib, muscle, rib, right? You know, so you're looking at the ribs in cross section. But you know, sometimes it's just ergonomics and or where the fractures are. Sometimes I'll turn it to where I'm in plane with the rib. Patients don't like the needle to go across that broken rib, but my favorite is to then pull off of the rib and look at the serratus above and the intercostals below, and just go right in that plane, because there's nothing in your way. There's no bones and anything. You have to know that it's great when there's a chest tube there, but you got to know if you lose your needle, you could stick it right in the lung. But honestly, that's my favorite approach, because I can take whatever angle I want, and I don't have something, you know, bumping up against my 2E needle when I'm trying to put it. Do you guys do that? Try different angles or approaches like that?
Um,
I think after the initial bolus, it opens up a space, and we generally advance the needle into that space, and then we thread the catheter. And then if the catheter doesn't thread past the needle point, it doesn't matter, because the needle's already where we want the catheter to be. And so we don't force the catheter in anywhere, especially in like patients who are on anticoagulation. We just use the needle to go into that space that we created with the bolus, so that we can thread the catheter easier. I guess it's very similar, but
Right, but you know, you could do it with either ribs in cross section,
yeah.
or you know, with the ribs. I mean, that's the point I'm also making with this, to tell the listeners, you don't have to do it this way or that way. Like you say, just get into the plane here, there, or wherever. You don't have to be this angle or that angle to get in there and make it work.
Yeah, any orientation.
Yeah, so let's actually opens up to our next question, since we've sort of discussed what happens once discussed the challenges of getting the catheter in the correct spot. But well, now that it's in, what do you do with it? Dr. Jones, so let's say you're using a catheter. How do you set your catheter infusion rates?
Well, that's a great question. So we used to use continuous infusions, and a couple of years we switched to pulse dosing or auto bolus. So instead of just kind of a continuous dribble of, say, depending on which block and how many ribs you're trying to cover, of, you know, say 6 or 8 or 10, 12, 14 cc's an hour, we found that when we auto bolus, we chose an interval of 3 hours, we found that, say if I'm going to do an ESP and I think it's going to be a rate of 10 or 12 or 14 an hour as an infusion. When we did that as a 3-hour auto bolus, because, you know, kind of shoots it out there with more force, we were able to use the same numbers. So it cut our utilization into a third. So 12 cc's an hour is now 12 cc's every 3 hours. And our, just kind of a ballpark, like I say, ESPs, assuming you have a lot of fractures, it's, you know, 10, 12, maybe 14 cc's an hour. Serratus, maybe 10 or 12. Parasternal, 6 or 8. And again, those were our continuous infusion per hour. But when we switched to the auto bolus Q3 hours, it'd be basically the same numbers, more or less. And then we allow the patients, they'll have a patient bolus where they can give themselves, you know, 5 cc's every, you know, hour or period of time. So I'd say every 3 hours usually.
Dr. Hernandez, Dr. Ramligan, are you guys doing anything different? Are you also doing these auto boluses?
So in our trauma unit, we don't have those pumps that can do it, the intermittent boluses. So basically, I put an order for the nurse to do it if the patient is unable to. Same as Jerry, I use every 3 hours for the nurse to bolus 8 mils if the patient's unable to. Otherwise, I'll use, you know, on average 5 to 8 mils bolus size for the patient every 30 to 60 minutes. But most patients don't use it that often.
So we also don't have the capability on our pumps to do programmed intermittent bolusing quite yet, although we have been working on it for 2 years, and I heard it's coming next year. So We do, unfortunately, we do continuous infusions still. Our max, 20 cc's of 0.2% ropivacaine per hour. And so we'll divide that up based on, how many catheters there are and where are the most rib fractures or where's the most pain. But generally for the fascial plane catheters like serratus or even ESP, it's very similar to what Jerry said. It's like, usually we just start at 10, unless there's like very little rib fractures, which we never block those. And if there's a lot, we might go up to, 14. I don't think we've ever gone higher than 20 on both. For the parasternal catheters, it is lower volume. I think we start them off at like 6. And if they need, because the sternum usually breaks in a transverse orientation. Most sternal fractures are transverse. And so, actually, if you put the catheter right where the sternum is fractured, you don't need really high volumes for the sternum, which is good because the sternum usually requires bilateral catheters. So that's good. That's good news. And, if we have one fascial plane catheter and 2 parasternal catheters, we'll even go as low as like 4 cc's an hour on those parasternal catheters, as long as the catheter tip is right where the fracture is.
Great. And so Dr. Hernandez, keeping with you for a second. So, all right, so now you've done your block or blocks. Your patient's starting to feel better. What do you do? How do you monitor these blocks to confirm that they keep working? How do you observe them? Do you need to do any kind of special monitoring on the floor? What do you do if they're having breakthrough pain?
So we actually don't do any special monitoring for fascial plane catheters, and we will send them home, with just themselves in our patch with an on-cue ball. So we'll have fascial plane catheters anywhere on the floor. So there's no extra monitoring if we do this. We do monitor the patient after the initial bolus for 30 minutes for any signs of local anesthetic toxicity. We have certain policies where you can't give any local if we've already have some catheter infusions going. So our trauma center loves lidocaine patches. So we read an order in the chart sort of not to give any extra local anesthetic. So there's a lot of different ways to know if the block is working. I may be a little barbaric in that I push on the fracture site.
Oh, I thought I invented that.
It actually.
I'll ask them at least. Do you have pain at rest before I mash on them? But yeah.
Usually, I ask if they feel better, and they'll say yes. Most of, 99% of the time they'll be like yes, and then I push on it a little bit, and they're actually very surprised. Then we hand them the incentive spirometer, and we make them take the deepest breath. Usually, we have a baseline recorded somewhere, or we do one before we get started, and see if we made any changes. Oftentimes, it's hard to quantify. Like if you go back and look at the chart, it's really hard to tell because they're going to ask for opioids for other fractures and other sources of pain. And the pain scores are sort of global, right? Like they'll put a pain score of 8, even with our catheter in. And I've had surgeons tell me the catheter's not working. He has a pain score of 10. And I'm like, yeah, his acetabulum hurts, dude. Like the catheter.
It's a Foley catheter.
Yeah, the rib fractures don't work. So we record site-specific pain scores when we're on service. His pain score for his ribs is, XYZ. His pain score for his, vertebral fracture is XYZ. And so that's how we sort of assess it. And if they have an increase in pain, we'll check to see if the catheter has moved or what is going on. If, they got something else going on. That's how we usually do it.
Oh, no, I was going to. The other bit is that other objective, because they can say, like you say, any number in the world. I want to say, okay, if I've done a parasternal block, we walk around with a bunch of alcohol pads in our pockets and just say, do you feel me touching you? Is it cool? Okay, now go this way. Tell me when it gets cool. Tell me when it gets cool. Then you can say, look, you got a big wide band of decreased temperature sensation, and that thing that you're saying hurts. Do you mean pressure and tightness? Yeah. Well, that's pressure and tightness. Go on, and I don't do anything. But if you saw one side, you had a big square on the chest that was decreased temperature, and then you maybe had a skinny little band on the other side. You go, maybe that catheter's out of the place, and then figure out, something to do about that. But pain numbers are just numbers. So, I'm sorry. Go on. You were just talking about breakthrough in the multimodal and stuff, right?
Oh, yeah. So interestingly, at our trauma center, we don't manage medications on the rib fracture patients, or really the polytrauma patients, right? Because we very rarely have isolated rib fractures. Our trauma surgeons published a paper called the MASS trial. It's on multimodal analgesia for polytrauma. And so they do the same thing for all of their patients. And it's like a gabapentinoid, Celebrex, Tylenol, and then they do, a low-level opioid. And if they need us, they'll call us. But so everyone sort of gets the same thing. And we don't, if they need extra, they'll just call us back to reassess the catheter. So.
Yeah. So yeah, you mentioned the Tylenol or acetaminophen, whatever. Do you guys, because we use IV acetaminophen at least 24 hours and reassess, 24 hours and reassess. At some point, we're looking pretty good. We go to PO. Do you guys ever use IV acetaminophen?
I wish our pharmacy would let us, but
I hear you.
But due to the cost, they actually, if the patient is taking PO, they won't approve an IV order. So we can only order it if the patient is NPO, unfortunately, at our institution.
Yeah, I hear you.
Yeah, we recently got it, and we use it for long cases intra-op, and select patients on the floor who can't take PO.
Yeah, I mean, I have been on, at least with that end of it with pharmacy. The way I've framed it when I said, no, this is important. They're like, well, they can take PO. I said, well, they uptake, they don't get as much. It makes a difference. And like Nadia, like you said at the very beginning, if these patients don't breathe well, they go to the ICU and they go on the ventilator. And if they go to the ICU on the ventilator, that's a $10,000 day. So that was my, listen, I need to do everything I can to keep them like I need to keep them so they're off of narcotics and not there. And so I put it in, when I was doing my initial, not that it'll always work, but when I did my initial sort of conversations, it was like, look, this is a $10,000 decision and this thing cost $100. So I want to, and we said, we'll be thoughtful. We'll only order it 24 hours in review or, reassess if we think they needed another 24. But honestly, if you put your catheters where they ought to be, in my opinion, and then you get all the multimodal, like you say, gabapentin and, some non-steroidal and on, you really don't need it for a long time. But that was my argument, how I framed it to my pharmacy.
Dr. Remligan, I just want to ask you a little bit more about your approach to managing catheters. Since these can be kind of tricky and a little finicky, do you have any tricks to get the most bang for the buck out of them?
Yeah, well, after all that work of putting it in, you want to make sure it doesn't come out. So actually, I spend more time on the dressing.
Amen.
The dressing takes me longer than putting it in. So I use everything that is available to me. So lots of glue. We have this anchoring device called an EpiGuard, which is like really for epidurals, but I use it for peripheral blocks as well. I use steri strips, and then on top of all of that, some tegaderms. And then the connection port, I put it like on the anterior chest, somewhere where I know the patient's not going to roll on it and it's not going to come out or get pulled. Yep. The other thing I told you about earlier was making sure that the patient and the nurse know that bolusing is important and not to rely simply on the infusion. And this often needs to be reinforced daily because the patients forget or the nurses change patients. And so you have to explain to them that, we think that the bolusing is going to increase the spread. So it's important to do that. Some catheters have metal in it. And so if the patient is going to be going for an MRI, you may want to use something else, like an epidural catheter that doesn't have metal. And the other good thing about epidural catheters is that they're multi-orifice, at least the ones we have. So it's less likely to get blocked and potentially might even increase the spread of your local anesthetic. because most of the peripheral nerve block catheters are just single orifice.
Well, thank you. And Dr. Jones, Dr. Hernandez, do you guys have any pearls of wisdom you'd like to add?
To have anything that's not compatible with MRI, because we had so many issues with patients going urgently or like there are people taking out catheters that took us a very long time to place, and then being in pain overnight. And so, it's a good point if you don't have a system in place, or you're at a place that has a lot of different types of catheters. He does make a good point. We use Dermabond for the skin for most of our catheters. So our dressing is quite expensive, I like to say. It takes a lot of time, but it's also expensive. But we have to make sure that local doesn't leak out of the skin and wet the dressing, and then the whole thing just comes out. And so, we do something very similar. The only thing that I actually have a question for the group more than more pearls, because I feel like we're all very much on the same page, is how long do you leave your rib fracture catheters in?
Both of you. I think the other tip that you implied, or inferred, is when you're done with your ultrasound, make sure all the ultrasound gel is gone, no blood, the Dermabond or the 2-octyl cyanoacrylate glue, because there's many of them. Let's not say we're necessarily saying them, but you've got to make sure that it makes contact with the skin. So, we have a very specific dressing protocol, and it's that you got to get all the goop out of the way, that stuff right on the skin down the catheter, and then steri-strips and whatnot, and then you protect it as much as you possibly can, taping down the catheters and all of that. But I will say, so that's we're on the same page there. Once the backtrack comes up onto the skin, whatever you put there is worthless. It's all going to get wet and gooey. You've got that is in like other glues that are not 2-octyl. They don't work. They get hard and crack. But you're saying how long to leave catheters in? I will tell you where we are now. Lots of rib fractures, they hurt about a week, 5 to 7 days, something like that. Sometimes they're longer. But I'll just say for our catheters, and we end up managing. We do all the multimodal and we do all the catheters and stuff. We leave our catheters in. Well, let me say it this way: we trade them out every 2 weeks. So if it's been there for 2 weeks, not that there's a problem, but that's our protocol. We just pull them out and replace them at 2 weeks or something like that. And we do not, rarely do you even see red skin or anything, but that's also, check your dressings every day, make sure they don't leak, make sure they're going well. So that's ours. It's about 2 weeks. Not that we stop them, we pull them out, put them back in if we need them. But that's not.
Well, thank you, Dr. Jones. I'm wondering about any other risks that we need to think about with these nerve blocks, bleeding, infection, anything like that, and any procedural or protocol things we should do to minimize those risks?
Yeah. Well, what I've just one last point about the toxicity. Most of the incidents of toxicity from blocks happen when you give a big bolus. With catheters, if you see it, it's maybe 15% of the time, and they usually have very, very slow onset. And like I say, we do ours Q3 hours, so if we have several, we'll just offset it like noon, 1 o'clock, 2 o'clock, so they don't get all of their boluses at the same time. But honestly, we don't really see it, or maybe it's a little bit of ringing in the ear that kind of lasted. Turn it off. Turn it back on at a rate a little bit lower to keep moving. It's not an issue. And like I was talking about with our the catheters, leaving them in. We leave them in. Now we look at our dressings every day. We're meticulous about them. But I can't tell you if we've had red skin. We had one catheter patient we sent home and had some costoclavicular block that had a serratia infection, and that was it. But this is with hundreds and hundreds and hundreds of catheters. We don't really ever run into infection risks, issues like that. And bleeding is all, that's why I say we stay away from thoracic epidurals. We do these other things. There's blood in those spaces anyway. I've not really run into that if that's what you mean, like needle trauma and things like that. That's not been a big thing. I think that the biggest risk is, whoops, it came apart or came undone, or the dressing got messed up, if you want to say, as a complication, so to speak.
Sure, thank you. Yeah, I'd say it's been my experience as an intensivist that it seems like I rarely see a problem with a peripheral nerve block or a fascial plane block or any of these blocks.
Mhm.
Um, Dr. Hernandez, I'd be curious to pick your brain about this. So we talked a bit about potential problems with the nerve blocks, but I'm wondering about just the approach of doing multimodal analgesia for chest wall trauma. Do you see many problems with multimodal techniques, and how do you avoid or manage them?
I will say the biggest problem we see with multimodal is probably a little bit of sedation from, high doses of gabapentinoids or maybe even some of the
Mhm.
muscle relaxers. That's probably the biggest problem that we see. Um, we try to use the GI friendliest of the NSAIDs if possible. Um, Oftentimes, if our patients also have an AKI, though, it really limits whether or not we can give certain medications or the doses as well. And there's a specific patient population where we can't really do multimodal, and that's unfortunately in the patients who need it the most, which is the elderly population. So
Mhm.
in those patients, our geriatricians really just only want acetaminophen, regional anesthesia, and hugs. So, if we can avoid opioids in that patient population, uh, because our only other option is really acetaminophen. Our geriatricians are very strict with polypharmacy in that patient population. So that ends up being our biggest problems. Our surgeons are okay as far as like from a bleeding standpoint doing NSAIDs, but unfortunately, with trauma, you get some multi-organ dysfunction on occasion.
Sure, thank you. And Dr. Ramlagan, do you have any other considerations?
Yeah, we've actually started cutting back on pregabalin as a routine part of multimodals as well, because of the sedation and lack of good evidence, really, uh, especially in the elderly. Um, we also use a lot of ketamine infusions, like ultra low dose, um, to minimize opioids, like 4 to 6 milligrams an hour. And often these patients may come in like in the middle of the night, so they may not be a regionalist around. So we'll start them on a IV lidocaine to temporize until the next day.
So we've had a chance to talk about all like the knowledge background, logistics of placing and securing the catheter. I guess it's time for some of the non-technical skills. The last topic we want to discuss about is the active patient management, such as recovery goals, expectations, and education. Dr. Jones, did you have any comments on that?
Well, I have lots of comments and lots. I think that's the main thing. Get the patient like you want them. Then let's make some things happen. So my goal for the patient, and I bet you it's going to be similar to what these guys will say, is I want the patient wide awake, alert, actively involved in recovery, which in this is usually doing your incentive spirometry and coughing. And our routine is 5 big breaths and cough every 30 minutes. If you feel pressure, you just keep going. You don't stop the pressure. If it's sharp, you hit your button, to get a bolus or something like that. And I want them to be in a position where they really don't need any opioids at all. And let's say we're talking here again primarily about chest wall trauma. My goal is that I want the catheters to cover all of the places that are doing that. And so we tell them, like, yeah, I want you to take deep breaths and cough so we can get off the oxygen. I want you to get up and walk. I want you to get going. All this, let's remove all the discharge barriers and get you out of here. And what we also said with this active management part is what was already kind of hinted at a few different times. It's educating the patient, the nurse also. They can't just say, my pain's a 10, fall asleep, give them narcotics. Do you mean pressure? So re-educating the patient about pressure. Pressure's pressure. Pressure's not pain. We expect that. And then sort of the opioids are bad, talk about that sort of thing. But that, I expect them to be actively involved in this. And it really does take a lot of education, or really re-education with the patient. And what I find is 2, 3, 4 days in, they really get, hey, look, give me my incentive spirometer. That's what I tell them. That's your teddy bear. It should be sitting on you all the time because you're always going to be using that. So it usually takes a couple of days for them really to figure that out, or to realize they think it's going to hurt. But if you're always taking deep breaths and coughing, the pain's not going to sneak up on you, and you've proved it to yourself. And it's almost like they have to get over that barrier. So Oh yes, I'll talk too much. So let me back away. I want to hear what everybody
Yeah,
else has to say about this.
I think that's gonna be my new statement. That's your teddy bear.
Yes, that's your teddy bear. When I see it all the way across the room, no, your arms aren't that long. That's got to be right over here with you. You need to be using that.
Dr. Hernandez, did you have anything to add to that?
Can't tell you how many times, there's a mental status change or whatever. Everybody always blames anesthesia, even when we're not in the OR. And so they will turn off my catheters. And so, we always have to, especially when we do new things or there's high turnover in certain units, we'll try to make sure that we have some ongoing education about the low chance of anything really, happening from these catheters being in there. Yes, thank you for looking out, but don't just turn it off. Please call us so that we can assess, because we're gonna spiral, and then we have a bigger problems on our hands. So
yeah, I'm so happy to hear. I hate it, but I'm so happy to hear somebody else say that. Like, oh, the patient farted, so I thought it might be toxicity, so I turned it off, and now they're on the ventilator the next morning. Like, yeah, like, come on, guys, and you know.
Yeah, I have the same experience. So the patient gets delirious with sundowning, and they think it's the catheter. They stop the infusion and start giving opioids once he starts getting pain. So yeah, you need to educate the whole team, basically everybody involved, that we want to avoid opioids. This is why we're doing these catheters and using multimodals.
But you guys said, one of you said it before. If we ever see weird symptoms and stuff, 99 out of 100 times it's the dose of gabapentin, and they're seeing weird stuff, and that's what it is. So same thing. You got to minimize that.
Dr. Jones, at some point, you have to do away with these catheters. They can't stay there forever. So, what time do you clamp them or pull them? Do you ever send patients home with continuous catheters?
Yeah, and that's actually important part of making that decision about who gets them and how long they need to stay in the hospital. So what my way of looking at it is, I don't want the patients hurting, right, and having nociceptive input. But what I kind of watch is watching the trajectory of their pain. You know that a lot of fractures, these, like I said, they're going to hurt 5 to 7 days or whatever it might be. So you have an idea what it might be. But what we end up doing, we kind of track the infusions or the autobolus rate that was necessary, how many times the patients got hit, because you'll see they're hitting their button 15 times, 12 times, 6, 2. So if you're not needing them so much anymore, and they're not, we're not having to escalate multimodal or do those things, you can kind of have an idea what the trajectory of their pain is. And then when we see all, the other discharge barriers have been met, they can walk, they can eat, they can do, whatever they need. And we see that those things are happening. Hey, we don't need any opioids. What we do is we plan what we call a clamp trial. So either at 4 or 6 in the morning, maybe depending on what kind of blocks they are, we'll have the nurses turn those infusions off. And basically what we do is then we watch and see how long it takes for the patient to start hurting. And the order says when they start hurting, turn it back on, right? Then we can say, wow, you went 12 hours, or hey, you went all day and you didn't even need any opioids. Or when we used to use a continuous infusion device to send patient home with, I could kind of figure out about how long it would take for them to start hurting, to go, oh, this elastomeric pump will last you about 2.3 days. So how long, so I could figure out, so I could send this pump home with you, and in 2.3 days, you'll have a nice soft landing. If somebody starts hurting, within a couple of hours, they're going to have more than 2 days worth of pain. If they can go 6 hours or more, and it's starting to ache, it's starting to bother me, well, that tells you, well, if I turn this back on, I bet if we fast forward 2 days, you're going to be about right. So that's kind of how we do it. And then you have to, I think a big point is, you want to make sure you can't send somebody home that if their catheter gets disconnected, that they're going to have respiratory failure, right? You have to have someone that, okay, you're healthy enough, you live close enough, you're relatively responsible, you have help, so that worst case, if this messes up and you just can't get back to us, it's more going to be like a bumpy, terrible landing. It's going to be rough, but you're not going to, suddenly develop a pneumonia because you couldn't breathe anymore. So taking those patient factors and how we kind of follow the trajectory of their pain, then we say that's how we use our clamp trials to kind of give us an idea for.
Oh, great, thank you. Thank you, everybody, for this great discussion. Thank you very much to Doctors Jerry Jones, Nadia Hernandez, and Riva Ramligan for being our panelists today. And thanks to Doc Matters for hosting us. If you're interested in being a future panelist or discussion expert for a Trauma Anesthesiology Society podcast, please email us at the links below. Until next time.